I know typically I kick this off, so I will. Uh, our agenda today is pretty straightforward, but I think what it is it's really great to have to start to keep taking a deep dive into how we're going to utilize our resources, how we're going to develop a true bidirectional e-referral system, and how this will ultimately help with our care coordination. So having said that, I do want to welcome you all, and I'm going to hand it over to the introductions and all. I'll hand all of that over to Caitlin. But I did want to say that we, just to set the tone, is that the CCCT is following the essential public health services. I mean, we're working on equitable access. We're building a diverse, skilled workforce. We're improving and innovating in this space, and especially we're doing the evaluations that are needed to do improve quality improvement. We're building and maintaining strong organizational infrastructure, and that's those are just part of a subset of what the services are. But ultimately, we bleed into all of it because because we're sitting in the Health Action Coalition, which ultimately does the assessments and policy development. So what we are is a true arm of a public health service. And that's what I want you all to understand, the importance of the community of our CCCT. It is a strong piece to help assure the community that public health services can get done for people who need those services. And we're going to, in Prince George's County, we're going to build that infrastructure. I'm very optimistic about building this infrastructure. I see that, especially if things go right in this country, we could build, and Prince George's County can be the shining star in showing how to change health outcomes with building sustainable public health infrastructure. And that starts honestly for our communities, that starts with our care coordination and doing it right. So I think we've been taking those steps. And I just wanted to set that tone because I'm excited about the CCCT. Sometimes I know when you all come to meetings, you need to see what the broader picture is. And the broader picture says that Prince George's County is one of the few places in the United States. There are other places, but it's few places in the United States that has started to build that infrastructure. And we can then leverage all of these other things that are coming down the pipe if we have the organizational infrastructure in place and if we thought through how we're going to implement. And so that's what I'm looking for you all to do with when we have these meetings. We're thinking through how we're going to make this thing work, really work for our homeless population, for our people who are underserved, our people who need food, people who just need to understand how to prevent from that, do preventive care. So that's what we're about. I mean, that's strong. It's very, very strong. And if we keep the momentum that we have, then we will get there. And I'm filled with this optimism and enthusiasm about this. So having said that, I'll hand it over to Caitlin to do the welcomes and introductions.
Absolutely. So thanks for that bright energy on our Thursday morning. I agree that Prince George's County is really leading the way. Everybody is kind of already doing it. I think you all know the drill, but please introduce yourselves in the chat. Just say your name and your organization. And then is anybody joining CCCT for the first time ever? And if yes, please feel free to unmute and introduce yourself. Once, going twice.
I think actually this might be my first meeting.
Oh, Dr. Levy.
So yes, good morning, everyone. And I'm sorry I was a little bit late. I'm just here to listen and to take it all in and see how I can help. Thank you for all that you're doing. I know this is a labor of love, so we truly appreciate it. So good morning.
Awesome. Well, thanks for joining us. This is, this work group is amazing. So I'm glad that you're here to see it. Let's go to the next slide if you could, Taylor. All right, so we talked about our meeting agenda. We'll do some work group updates to talk about what we've kind of been working on since the last meeting. Then I have my brilliant health and wellness folks on this morning to talk a little bit about the work that we've been doing to integrate Epic with FindHelp at the Prince George's County Health Department. This goes obviously towards our goals of integrating a community resource inventory into our tech platforms. And I think they've been doing yeoman's work on that. So I'd love to highlight them as an example of something that can work successfully. And then we can open discussion and then have our community announcements and adjourn. So we'll just talk, just to refocus us on the mission and vision of CCCT. So our vision is that Prince George's County is a place where everyone has access to high quality and effective healthcare services that are well managed, seamless, and tailored to their specific needs. And our mission is empowering healthier lives through efficient care coordination with a strategic systems approach. All right, so we'll just go through some updates here. And Stephanie and Taylor and Dr. Carter, please jump in if I have forgotten anything. But I want us to always stay focused on the goals and strategies that we set in our community health improvement plan to make sure we're stayed driving towards the change that we'd like to see. So our first goal is to identify and improve connectivity with existing community health resources. So as y'all remember, we had 211 come and present. We learned more about their platform and its strengths and limitations. Then we engaged with FindHelp. We had CG come present on the amazing resource that is FindHelp and the different integrations that they have. So that is kind of where we are. We've engaged with CG. We have the CRI, I think that we're all kind of wanting to invest in terms of the most robust free resource. And we now want to start working on encouraging the addition of community resources to FindHelp. So I think FindHelp has a feature, and you guys will have to kind of jump in here, where they allow you to take ownership of your organization's page in FindHelp and be responsible for updating the information and sharing all of the resources that you have available and can help with. We would love for everyone on this call to take ownership of your own community resource, but also to take a look at who's in there and who's not in there. So a major goal of this strategy was to capitalize, I think, or create some synergy or collective scale for all of this work that we're all doing in our individual organizations, where, I mean, we all have resource lists, right? Like on Word documents or in our Teams groups or somewhere, we all have a list of the different resources that we refer folks over to. So we would love to get all those lists kind of integrated into one system. So we're leveraging all of that individual work that we're doing to make a robust resource within the county. So that's where we are with that. Does Dr. Carter, Stephanie, or anyone want to add anything to that goal that I missed?
That's exactly correct. That's good.
All right, cool. Sounds good. And then goal 2 is promote data sharing between healthcare providers and homeless response systems. So way back pre-pandemic, homelessness was the big issue that we were working on, fixing that sort of uncoordinated care coordination system. And big surprise, not really for those of us in this world, it's still a big issue, maybe even arguably a worse issue after the pandemic. We have a very fragmented homeless response system, and we're not well integrated between the healthcare providers and the homeless response system. So one of the things we've been working on with our incredible Jay Summerlot as kind of the driver here is working with our regional HIE, which is Chris, to support bidirectional information exchange and data sharing between healthcare providers and homeless services. Yes, Jay, right on time. So feel free to chime in with any additional information. But essentially what Jay pointed out is that hospitals and a lot of healthcare providers are now required to do this social needs screening, and yet it's not necessarily super well integrated what they can do with that information. So we're interested in creating sort of an automated or a text solution where when they upload a patient's social determinants of health screening into CRISP and it comes back positive for homelessness or unstable housing, that then generates a referral to social services and the homeless hotline so that Jay's team is able to both quantify the amount of individuals that we have in the county experiencing this, because our data is not great there, but also to make sure that we're reaching out to those folks and getting them connected wherever we can to any resources that are available. Jay, did I miss anything on that?
No, that sounded like a great summary, Caitlin.
Okay. All right, cool. I got 2 gold stars from the team today, so I will take it. So that's where we are with that. I'm super excited about this. And I have to say, Kim and I, and I'm sure Taylor as well, we found this resource that was, well, Kim found it, Community Solutions and their homelessness data sharing toolkit, which is kind of like a national organization. And like, we are doing exactly kind of what the best practice is in the field and with our tech solutions. Like Dr. Carter said, we're right on the cutting edge of this. Yeah, Jay?
I was just going to chime in. Community Solutions is also the organization that created the Built for Zero protocol, which we've just joined. And so we are actually getting technical assistance from Community Solutions to, we have chosen as our focus population, people experiencing unsheltered homelessness. So over the next, hopefully over the next year or so, we are going to be getting to functional zero for unsheltered folks in Prince George's County. We are also, the Metro DC region has joined the Built for Zero protocol in getting to functional zero for veteran homelessness within the next couple of years. So Prince George's County is actually getting support from Community Solutions in 2 different populations for whom we will be ending homelessness. And it is going to need to be an all of government effort. The meeting that I was just coming from and was running a little bit late, I apologize for my tardiness, was our street outreach meeting, our community street outreach meeting, where we were just talking about exactly this. iMind Behavioral Health was in that meeting. We were talking about integrating information from the behavioral health system so that when people are identified by their teams who are going out and responding to people from 988 calls, if they identify that people are experiencing literal homelessness, they have the direct connection to route them to our teams. And I mentioned the efforts that we are making in integrating our somatic health systems, information systems into that same kind of effort. So yeah, there's a lot going on right now, and it's very exciting.
It is very exciting. So we are super happy to have the right folks at the table to finally move the needle a little bit. Fingers crossed. All right, does anyone have any questions or anything they wanted to add about our goals or where we are currently? All right. Could you go to the next slide, Taylor? Thank you. So I will now kick it to my team, who I am endlessly proud of all the time. So Tornisha Stokes is our program chief of chronic disease and truly just the driving force in the health department towards making change in the areas of chronic disease, diabetes and hypertension, cholesterol, all that kind of stuff. She's also our project director for Prevention Link, the first one, and then the second one, continuation grant, which we've gotten, which focuses on initially diabetes, heart disease, and stroke, now diabetes, but is doing excellent work in that area. And then we have Dr. Mike Zenny, who is another brilliant mind. He speaks like 7 languages and manages our team of community health workers and is another sorry, well, just is that who was driving? Is another brilliant mind in our area of care coordination. And then finally, also a doctor, Austin Amuda, who is he's always telling me, okay, I'm not the IT guy, I'm an informaticist. So for those of you who know the difference, he's an informaticist and also a physician. So I will turn it over to my team to talk a little bit more about our work at the health department to integrate Epic with FindHelp and really work on kind of integrating those tech solutions to improve our kind of referral tracking and overall care coordination. Turn it over to you all.
Okay, can everyone see my screen?
Yes.
Yes, you can. Okay, good. All right, so I will start with just a high overview of Prevention Link, and then Austin will go into more of the IT component of the presentation. And I think Mike had a conflict, so I think he will not be able to join. So with that being said, Prevention Link 2 is, we call it our new program because we actually had Prevention Link 1. I'm sure plenty of you heard all about the great work we did under Prevention Link 1. We continue our work with Prevention Link 2, where we bring together stakeholders with a shared goal of advancing health equity for priority populations. Our priority populations includes adults and children, African Americans, and Latinos. The goal is to improve health outcomes for adults who are at risk for diagnosis with type 2 diabetes and children who are overweight and obese. We used to talk about bidirectional e-referral, but now we're moving towards multi-directional e-referral, which is known as MDR. We're using that system to connect patients with healthcare providers and also to support two-way electronic exchange of information between healthcare and community-based organization. So this is mainly what the presentation will be about today. The goal is also to provide access to CHWs who assist the participants and patients with eliminating social determinants of health barriers that prevent them from participation, affecting evidence-based participation in evidence-based programs. Want to move? IT? Okay. And so some of those evidence-based programs includes the diabetes prevention programs. And under the diabetes prevention programs, there are several of them, which includes the National Diabetes Prevention Program for 18 and older adults, and then Medicare Diabetes Prevention Programs, where Medicare cover the cost of the programs, and then the Health Choice Maryland Medicaid DPP program, and that's covered by Maryland Medicaid, such as the MCOs. We also offer the Diabetes Self-Management Education and Support Services, known as DSMES. Those are for patients who are actually diagnosed with type 2 diabetes. And we're also rolling out, which we're really excited about, our Prevention Link Kids and Families program, which is basically a family-based behavior treatment program for children ages 6 to 18. And the families are a big part of participating in this program to change behavior. Also, we are excited to announce that we are Prevention Link, we are Umbrella Hub. The health department is the Umbrella Hub organization. We have several subsidiaries that's part of our Umbrella Hub, which includes community pharmacies, federal qualified health centers, and community-based organizations. And basically the goal of the Umbrella Hub is to help organizations who would like to be a DPP supplier or are actually teaching DPP classes to basically focus on providing the classes to the participants, and we will focus on the administrative component of the program, where we assist with billing and actually contracting with Medicare and Medicaid. So now we are Medicare supplier, and we also have contracts with several of the MCOs, and we're in the process of contracting with the federal government to offer the services to their employees as well. And so now we are moving to the case study, which Austin will be providing an overview of how we integrate Epic and FindHelp to deliver the DPP program to these participants and also to eliminate social determinants of health barriers. And so, Austin, I'll turn it over to you. You on mute?
Thank you. So I'll quickly go over the scenario for this presentation. So Miss ABC is a 48-year-old African-American female patient that resides in Prince George's County and has been referred to the Prevention Link National DPP program by her provider. Miss ABC was struggling to control her blood pressure, her blood glucose levels, resulting in an elevated A1C and a BMI. Her recent A1C value is 5.9 and her BMI is 27.5 kilograms per meter squared. She was in denial about her diagnosis of pre-diabetes. She struggled to obtain sufficient food due to low income and transportation issues. Miss ABC wanted to figure out her own outcome, but later realized she had outside resources to help her. So the case is of a female 48-year-old. Practice is at Greater Bay Medical Services. Referred program is the National DPP. And the SDH assessment would be food insecurity and transportation. So what we did, please next slide, Tonisha.
This one, our article.
Okay. Okay, I was looking at my own slide. Okay, yes. Can you scroll up a bit? So this is the workflow for this presentation. The provider creates a referral for the national DPP and also notes that the client has food insecurity. And so what happens is the referral is made and then the central referral system, which is housed at the Prince George's County Health Department, retrieves the referral and then conducts a client registration. When that's done, the client is then assigned to a program or an instructor and also is referred to the CAWs for an SDOA screening. So the two-part process here, the SDOA is conducted by the CHW, and then the client is referred to a community-based organization to address the food insecurity. On the other hand, the client completes registration with the National DPP program and is enrolled into the program. And then in closing the loop, the CRS would run the reports, and also providers can view those provisions, assistance that has been provided to the client. So next slide, please. So the referral process starts off with launching Epic, especially to the program choice, if it is national DPP. And so this is where this is a screen that shows where you start off the referral by launching Epic. Next slide. So for every referral that is made, the patient search is done first. And the whole idea is to see if a client has some type of treatment relationship with the health department or any, excuse me, or any of the Epic service areas. So we would search for the client, and if the client is in Epic, we would complete the profile, and then it would help pre-populate some of the fields, and then we can initiate the referral from there. But if it's a new patient in Epic, then we would have to take time to complete the profile and then create the referral as well. Next slide. So when the referral is sent, it creates a work queue showing all of the referrals that have been made. At the very top of the referral of this list is the referral that's just been made for the national DPP. So this is just showing you what the work queue would look like more or less like a dashboard showing all of the referrals that has been made. Next slide, please. Okay, so when the referral has been made, it has to be assigned to a staff. So what we're showing here is the referral being assigned to one of our central referral specialists, who's Monique in the health department. And so she will take on the task of completing registration and then assigning this client to an available national DPP program, as well as making that referral to the community health work organization. Next slide. There are several ways to get this referral to the community health organization, as well as to the national DPP program. One way we do this is through an in-basket message. So this is the referral to the community health organization, as well as the national DPP. And you can see at the top where we've highlighted the in-basket message. So we're going to send an in-basket message to both organizations with this referral. So it's the next slide. So this is showing the in-basket message to Trina, who's the instructor at the Health Department's National DPP program, as well as I've included Shirley because her account, she has an account currently, and so we had to use her for the slides. So she's representing the community health organization, and the referral is being forwarded to both Trina and Shirley. And you can see them make a little note stating that, sorry, go back, please.
Go back, hold on. Sorry.
So we made a brief note showing that the Trina would be addressing referrals for national DPP, and Shelley, the housing or food insecurity. Next slide. So this screen here is showing the referral message as it will appear on either Shirley's or Trina's screen. You can see where it's highlighted referral message showing that one referral was made or received. Next slide. And so we now take it, the rest of the slides will then show what happens when it gets to the CHW. So this screen is showing where the social determinants of health screening is done. I've just highlighted here the screening that has been done for food. So the first step is conducting an intake, and then the CHW goes ahead to do the screening for the social determinants of health screening. Next slide. So what happens after that is we've identified that there are food insecurities, and so the next thing is to launch FindHelp. And so on this dashboard, you can see at the very top to the right, you will see the tab that shows how you can get to FindHelp. And then FindHelp really is just to help find resources within the organization. So this client resides in Prince George's County. Zip code is 20774. So what we really just would need to do is click on FindHelp and then type in the zip code in that zip code field there and click search. Next slide, Tonisha. And so when we did that, we identified 514 programs that will be of benefit to this client. And then we actually had to cut a lot of the slides because there's so many, it would be very long if we were to show every step of the way. So this is showing 514 programs in the Upper Marlboro area that could assist this client. Next slide. So what this slide just shows is just some of the options. You can see the emergency food pantry at Fountain of Life, Great Springs Church, and the other options there. On the right-hand corner, you can see a referral note stating that the client is being referred to the Fountain of Life, Great Spring Church. And so that referral is being sent here. And so this slide here is showing it's showing the CHW's dashboard. And what it does here is it just shows you all of the referrals that has been made, and who the referral has been made to. So if you click on the summary box there for each of these clients, it will tell you exactly, it would say exactly that this referral has been made to this client. It would also state if the program have initiated steps to assist the client. There will be notes from that organization in the summary notes or in the summary section for each of these clients. So that's where we end the presentation. There are slides, like I mentioned, that there are certain aspects that we couldn't show, either because the development is still, or the project itself is still in the developmental stage, and we cannot use production slides. So we couldn't go further than that. But just to show you how on one screen, you can start off a referral, providers can start off a referral, and then that referral is being made to organizations, either it is community health workers or to a national DPP program. And then the CHW, the providers can actually go back in to look up progress made as far as addressing the client's barriers to attending the national DPP program.
Thanks, Austin. And so just to kind of recap what Austin was saying, so with our program, what we wanted to do is just make sure that the population health data is being shared among the provider, the lifestyle coach, and also the community-based organization based on the information that they need to see. And so we're able to enter, if referral is able to be entered into EPIC for one of these lifestyle change programs, such as the National DPP program. The lifestyle coach, the central referral specialist will go in, pull the referral to make sure that the patient is eligible for the programs, to make sure they're meeting the criteria. Once that information is verified that the patient is eligible, we also receive the consent form, which will be through Adobe Sign through the system, as well as the the central referral will do a initial SCOH. And if that patient is identified needing assistance with social determinants of health barriers, such as food insecurities, then that referral will be sent to the CHW. The CHW can then pull that referral and go through the thorough assessment and then connect that patient, refer that patient to one of the community-based organizations, for instance, like the food pantry. And then the CHW can see if that connection's been made and also follow it through the system in FindHelp. And then if not, the CHW can also reach out to the community-based organization to make sure that they saw the referral, to make sure that that patient is being connected, and then also update that information in EPIC as well, so that the provider can see the patient was connected to the DPP program and also the social determinants of health barriers was addressed. And so all of that will be in this multi-directional e-referral system. So that's the purpose of having these systems integrated and sharing that data among the care coordination team. Any questions?
Looks like Liz asked a question in the chat if any of these programs are available to uninsured or underinsured individuals.
So, Liz, so when we had Prevention Link 1, the programs was for all patients, insurance or no insurance. Now, because CDC want us to move to a sustainability model, so now we're billing insurance companies for the services. And so if the patient doesn't have insurance, so we have CHWs to assist to help them get connected to some type of insurance. And now we know for the Hispanic population, a lot of the patients don't have insurance. So we're looking for ways to make sure that they still get services so they won't be left out. And so they will be able to get services, but it would not be part of the prevention link part, but also there's still programs that providing free DPP services. So we don't just turn them away. We'll still help them get connected or refer them to those free resources. But with CDC, with our programs, Prevention Link, CDC is having us build an infrastructure to support sustainability models.
Yeah, so it's a tough thing. It's a double-edged sword with the billing. I know we're seeing that on the CHW side as well, that like they really want to move towards billing, but billing only works if you have someone to bill. So it's a tough thing. Yeah.
Thank you. Welcome. Any other questions?
Dr. Levy?
First of all, I want to congratulate you and the team. This is wonderful work. This is exactly what we should be doing to try to change the trajectory of health in the county. Just had a quick question. For the DPP program, do they have to be referred from a provider, or can they come from anywhere in the community?
They can come from anywhere in the community as long as they meet those eligibility requirements. And so they can do the risk assessment. But in order to bill, we will need their A1C level so they can do self-report and provide a copy of their lab reports throughout, because the goal is to monitor.
Hormones. So we check your female hormones. Let me just open this up.
Part of the goal is to monitor their A1C levels. In order to do that, we would need to know what their value is and to see if it decreased over time, because you get points and, performance measures, CDC used to determine your recognition if you continue to be full plus or not. And so the goal is to achieve 5% weight loss or either 4% weight loss and decrease the A1C lab value by 0.02.
Wonderful.
And
Sorry, go ahead.
Oh, I just want to say, and to sort of like zoom out a little bit and get a little more like theoretical, the intention of Prevention Link 1 was really to bridge the gap between clinical care and the public health system. So it's very much focused. The Prevention Link model is although we will accept, of course, like referrals from anywhere and we'll have any point of entry is okay. It really is a model that centers on the primary care physician as the manager of that patient's care. So it's adding to the provider's suite of tools where they can, if we want it to be as easy to refer to a public health program as it is to send a prescription to the pharmacy, and then to get that information back about how successful it was, to really sort of codify the relationship between the clinical sector and the non-clinical sector to sort of work on that integration for both the purposes of making patients healthier, but also the purposes of like billing and eventually getting really integrated into that system.
Great. I also love the addition of what is FindHelp is essentially community information exchange. And I think that's a wonderful process. And it sounds like you're trying to also connect all the dots there between Epic and CRISP and FindHelp so that it's a smoother transition of information across instead of having to go to one place and pull it into the other. So I think you're all doing such great work. That wasn't a shameless plug for my team. So.
We take it.
Can you guys talk a little bit about the role of external folks in this system? So I know, for example, that we've been talking to Liz and her team and anyone else who's involved with our community health worker efforts to get them access to the system. Can you talk a little bit about what that looks like on their side and the kind of role of an external provider in that system?
Yes. Austin, would you like to take that?
Yes. So I know the scenario I painted here we initiated a referral from a provider, but we can, there are several ways you can do referrals. You can do referrals within like the health department. And then we can also, is the outbound referrals, the incoming referrals. So for an external that is not within the health department, right now, what we would do is grant them access to Epic. So for the phase 1 of this project, we really just going to have to give them access to Epic. And so they'll be using this outside of their systems, their EHRs or EMRs. And so they can do the referrals. The other alternative is that we can have someone do the referral on their behalf. So they have their access, but we can do a referral on their behalf, and they should have visibility to the referrals. So anyone really outside could do referrals, but they would need to have access to the system.
Yes, and so Caitlin, they have to be VPN and have VPN access in order to get into the system. And there's, of course, tight security guidelines for them to have access. And so if they're doing a referral, they will only be able to see that patient, referrals, and insert information related to that referral. Yes. So we're working now with testing external providers for our DPP coaches, such as HCDI and Greater Baden. And so they had to, because at first they thought, oh, they need to have a county laptop, but that's not the case. They just have grant VPN access. Yes.
Liz, not to put you on the spot, but I'm curious how CASA intends to do. I mean, you may not even have any idea, because I think all we've done is ask you for email addresses. So, but I'm curious how that's going to integrate with you and your organization.
It is very interesting. We would love, well, yes, you are correct. All we have been requested for is our emails.
Yeah.
So it will be interested how we could use the program. The biggest, well, let me just ask this question before I trip myself even more up. All the services that are gonna or being connected, it is a billable system. Is that correct?
Well, I think that's true for the prevention link. So for like diabetes prevention programming, those types of services. But if you wanted to do, like, for example, a referral through FindHelp, that would be, that would be resource dependent. So if the organization you're referring to is like a food bank, obviously that's not a billable service. But if you were trying to get someone enrolled in a diabetes prevention program, that would be more so like billable. Did I answer that correctly, Austin?
Yes.
Yeah.
Okay. So for that aspect, yes, we, just like we use on a normal FindHelp, then we would use it. But for the other, 9 times out of 10, we won't be able to use it because we will be looking for resources or connections to clinics and stuff like that, where our community members can either get stuff at a lower rate, or because we do deal with the immigrant community, not just Latinos, and most of them don't have the access for one reason or the other to health insurance. So that's a big issue on our plates, right?
Okay, thanks for letting me put you on the spot when we've not given you any information yet.
No worries. No worries. I aim to please. I hoped I was able to answer your question.
Oh, that was great. Awesome. Does anyone else have any questions for Tarnisha and Austin?
All right. Well, thanks. If you think of questions later, feel free to email or reach out to me in Austin. Thank you.
Yeah, thanks. Thank you guys so much. I know we wanted to kind of talk broadly to see if anyone else has had, I guess to walk it back, the reason we wanted to present this to you all today is not so that you all can go out and buy a, multi-million-dollar EHR and then do an integration. The reason we wanted to present it is because we wanted to give an example of the way that, you know, you can work with the existing infrastructure in your organization to kind of build that integration out. And I will also say this did not happen overnight. Like, this is a result of, you know, 5, 6, 7 years of working on, you know, tech integration. So I know it's hard, but I'm curious if anyone else has tried something like this, and what your experience has been either with integrating FindHelp or maybe Unite Us or 211 or kind of whatever other resource inventory you may have or referral system you may have launched.
Well, since nobody's talking, I do want to say that, you know, the ultimate goal of integrating FindHelp into Chris was to create a way for people who don't have an EHR, who need to make a referral, to go through our state health information exchange. And ultimately, you know, in the original prevention link, when we and Virginia and a few other states were talking about how they should all lie in the health information exchange, and from the health information exchange, then it could then send bidirectional information to multiple EHRs, and you wouldn't have to integrate it into it. It would all come through the exchange. But you know, there are, you know, the exchanges actually weren't ready for that. So now, though, that Chris has started to integrate FindHelp into Chris, then what our goal then is to work with Chris to help organizations who don't have a sophisticated EHR that can integrate FindHelp into it, to be able to leverage that. But at the same time, for those systems that do have a sophisticated EHR and that uses FindHelp, they will be able to understand whether, if you know, once the referral is made and they happen to get that patient new or that client new, they would be able to download information from the fact that they already had, you know, connected to food insecurity, et cetera, because that's one of the bidirectionality helps you understand what the state of the client is at the time. So what we are trying, I think what we're going to try to achieve is that I think we had Chris come on and talk to us about how they integrated it, and now we're showing how the health department has stepped up to the plate and integrated within their FindHelp in their EHR. And they, you know, of course, it's a process, but ultimately our system, our care coordinating system, has to be available to everybody. It has to be flexible enough. So for the people who have using paper as and trying to make a referral, and the people who have sophisticated EHRs, there has to be, Chris plays an important role in making sure there's a central repository of this information. And you remember, that's why we're building those resources. So we still have a lot to understand about where Chris is in that development process, but we're getting there, because Chris has dedicated now the resources to get that done. And for Chris, then it gives us a way to be able to look at population health data analytics, because that's what Chris can do for us without us, for us, meaning that the entire community, so that you don't have to spend a lot of money trying to get the population health analytics. You'll already know that for the region of people that you're serving when you're doing care coordination. So I think one of the things that's really important here is to show how those steps occurred in the health department. The health department is doing a systematic way of creating their multi-directional e-referral system. And again, that's on the cutting edge. So I'm proud of I'm proud of Austin, because Austin is taking that to the next level. And that's a really good thing. So I think the CCCT, I wanted everybody here to start to understand how they can leverage Chris, as well as you know, being able to access some of the resources that the health department is developing.
So Dr. Carter, we've reached out to Chris. We don't have a scheduled meeting date yet, but we've reached out regarding our integration with them, the FindHelp and getting our data into CRIS. So that's in the works.
Awesome. Liz, did you have a question?
Yes, I wanted to know if with the integration of the CRIS and the FindHelp, are all of the features still available in Epic as they are within their own programs if you were to use them separately?
That's a good question.
Can't answer that. I can't answer that.
Yeah. Austin, do you know?
I didn't really get. Can you please repeat the question again?
Yeah, so for example, and this is the reason I brought up the question, is FindHelp one of the reasons that we use FindHelp so much is because we can either send an email to the community member or we can send a text. So that's a feature that is especially in our community, right? So I wanted to know if with the integration, did the integration limit some of the features of the other two programs, or were they able to completely integrate?
I don't think it limits it in any way. I think what it provides is having it all in one system, where you can launch it within that same system and not coming out of the system. So it doesn't. I don't think it does limit in any way.
Yeah,
Okay.
it doesn't limit the features. So they actually can message because we're working on like group messaging and individual messaging as well. Because there's another app within, Epic that you can send the messages to FindHelp. So they'll be able to do that communication through text. And we're also using that for our DPP lifestyle coaches as well. If they need to communicate, to the entire cohort, but when it's social determinants of barriers, that's individualized. So to each individual person. So those features are there.
Okay. Thank you.
Just Augustine, just I should be able to help facilitate a conversation with Chris. So we can talk offline, but I'm happy to try to move that forward. Because I agree with Dr. Carter. This is cutting edge. This is exactly what we should be doing, and communicating and connecting the dots so that we can coordinate care. So anything I can do to help, let me know. But I'm happy to try to facilitate the crisp conversation.
Awesome. Thanks, Dr. Levy. All right, let's roll ahead just so that we can stay on schedule here. This was a great discussion. I'm wondering if some of you, like me, kind of start to glaze over when we talk about IT stuff, but I promise this has cool on-the-ground implications for those of us in care coordination, because I will never forget talking to our CHW team and Denise like saying that she has to go like this to open up the Excel file columns big enough to be able to type in the patient's information. And I was like, okay, now something's got to give here. So we're making progress and it's very exciting. I'm excited that CCCT exists both to drive us forward at the high level, but also to provide us that feedback on the ground about if it's working or not, so that we can course correct and make sure our systems are working for everybody who is out in the community. Do we have any community announcements? I don't know, Taylor, if we have any. Okay, I will turn it to you for these.
Yeah, I can jump in, Caitlin.
Is that okay? Okay.
Yes, our Project Echo from Kennedy Krieger Institute, they came yesterday and spoke to the Behavioral Health Advisory Group. I know there are some familiar faces who are also on that call, but really exciting opportunity. Project Echo is expanding from the Eastern Shore to Prince George's County. There will be sessions starting on the second and fourth Tuesdays at that lunch hour from 12 to 1 p.m. on Zoom. The target audience that they are hoping to reach are physicians, nurse practitioners, physician assistants, really any folks who are working in the behavioral health space, and those who are working with children from birth to 8 years old with mental, emotional, developmental, and behavioral concerns. And so there will be didactic training offered during that 1 hour session where a case study will be evaluated. There will be questions that folks can raise about the case, and just a really great time for folks to be able to come together, be in the room, express some of their concerns, what they're seeing through their practices, and be able to come up with solutions together. And so the ask from the Project Echo team, Stephanie, if you could put that link in the chat for folks to go ahead and start registering for those sessions. Again, those will be starting on September 10th on the second and fourth Tuesdays of the month. There's a registration link for those who are interested. And yeah, this will be a really great opportunity. If you have anyone in your networks who you think match the target audience, or who would benefit from this, please share it out to them. We want to be able to reach as many folks to make this a success in the county.
Awesome. And Sharon, yes, we'll definitely send out the flyer and everything afterwards.
And that's the only community announcement that we had for the slides. Do any of our partners on the call have any announcements?
So I have a selfish announcement, which is that the Prince George's County Health Department Health and Wellness Division has posted our administrator position. It's a budget analyst. So if you know any folks who are really good with numbers, we need someone to keep us straight over here, and looking for somebody who's going to be part of our awesome health and wellness family. And yeah, so please share it with anyone you know who's like a numbers nerd. And it looks like our next CCCT will be September 26th at 11. And our next quarterly meeting will be virtual. It'll be on Tuesday, September 10th from 6 to 7:30. So make sure you're registering. No delicious food for the virtual ones, but we will still commune and have fun. So make sure you're registering for that. Does anyone have anything else before we adjourn for the day? We're perfect on time.
Perfect.
All right, my friends. Well, thank you all, and I will see you in a month.
See you guys.
Bye.